begin his presentation.
Hello, everyone. My name is Tushar. I'm a third-year cardiovascular disease fellow at the University of Missouri, Columbia, and I'm glad that I've got this opportunity to present this journal club for today. So we'll get started. The paper I have chosen to present is on cardiotoxicity surveillance and risk of heart failure during HER2-targeted therapy. This paper was published in JACC Cardio-Oncology last year around June, um, June 2020. So start with the background. What the authors of this paper describe is right now the guidelines recommend evaluation of left ventricular ejection fraction every 3 months for monitoring of cardiotoxicity with HER2 therapy. Though the guidelines have been, I think, since the introduction of the drug, the evidence in support of this practice is still lacking. So the objective of the study was to examine the association between adherence to cardiotoxicity surveillance guideline and heart failure in HER2 positive breast cancer patients who were receiving HER2 therapy. Left ventricular ejection fraction, like we all know, has been used as an important imaging biomarker for screening and then diagnosis of cardiotoxicity, which has been associated with cancer. In cardio-oncology, we use ejection fraction to determine a patient's eligibility to initiate and then also to continue treatment, especially for breast cancer when patients are on regimens which include anthracyclines and or HER2 therapy. Cardiotoxicity, which has been defined as heart failure or ejection fraction decline, is usually the most frequent cause of premature treatment interruption or discontinuation of sequential anthracycline therapy, which has been used in these patients. The reported incidence with this regimen, which does include the anthracycline and HER2 therapy, is usually 2 to 4% of patients develop heart failure, whereas asymptomatic ejection fraction decline occurs in up to 19% of patients. So the primary objective of the study was to determine to see if there's an association between adherence to the current guidelines for routine ejection fraction surveillance during HER2 therapy and treatment-induced heart failure. So this was a case-controlled study which defines cardiotoxicity in terms of severe cardiotoxicity, which was defined by NYHA class 3 or 4 heart failure or cardiac death that happened during HER2 therapy. So the methods that were used was, like I mentioned, it was a case-controlled study of female patients who were more than 18 years of age who were receiving trastuzumab-based treatment for HER2-positive breast cancer from stage 1 to 4 at the Memorial Sloan Kettering Cancer Center between 2005 and 15. To evaluate the association between the surveillance and risk of heart failure, the adherence to routines ejection fraction assessments was compared between these two groups of patient population, which were defined as case, as patients who did have heart failure or cardiac death, and controls were the patient who were matched to these cases. So how were the cases defined? So case patients included the women who did develop severe cardiotoxicity, which, like I mentioned, were heart failure symptoms and or cardiac death. The heart failure symptoms were from dyspnea to decreased exercise tolerance to fatigue, more than ordinary activity or at rest, which is NYHA class 3 or 4, and had evidence of new or worsening heart failure on physical exam and or diagnostic testing, which included elevated BNP and pulmonary congestion on chest X-ray or abnormal systolic function on echocardiogram. So it was a retrospective review of the echocardiogram database that the institution used for patients who were receiving trastuzumab and had an ejection fraction of less than 55%. The pharmacy administration of trastuzumab was also reviewed to see where there was an interruption or discontinuation of trastuzumab. Then they also reviewed the lab data, which were significant for elevated BNP more than 100, and their billing data, which used the ICD-9 codes for heart failure. Uh, Again, a review of the database containing cardiotoxicity outcomes for all cancer patient with adjuvant trastuzumab was also reviewed between 2005 and 15. So the 53 cardiotoxicity cases that they had, which were defined by the criteria that I had mentioned, were reviewed by 2 cardiologists to confirm that they all met the criteria for severe cardiotoxicity, and then each case patient was then matched to 3 control patients according to the age strata, prior exposure to anthracyclines, and year of treatment for breast cancer. Um, they also reviewed electronic medical records, which for both the case and the control groups, which included age at treatment, sex, body mass index, race, and the regimen that they were on for their cancer. The other variables that were also reviewed were the risk factors like hypertension, hyperlipidemia, diabetes, and tobacco use, use of concomitant cardiovascular medication, which included beta blockers, ACE inhibitors, ARBs, and calcium channel blockers, and history of cardiovascular disease, which included coronary artery disease, arrhythmias, or cardiomyopathy. Um, After they selected the cases and controls, they looked at the exposure of these patients to the surveillance, which was used through imaging studies, which included echocardiograms, MAGA scan, or cardiac MR, which was performed at the institution of the study as well as externally. And they also reviewed the frequency and timing of these surveillance ejection fraction assessments. Any cardiac imaging studies that were ordered for the diagnostic workup of a patient who did develop sign and symptom of heart failure was not considered, since it was not a surveillance study at that point of time. For the case patients, the time window of exposure to the surveillance test was defined from 6 months prior to the start of the trastuzumab treatment and then ended on the date of heart failure or death. The length of observation for each control patient was then matched to the length of observation to the case patient, so that there was equal window of exposure to the ejection fraction surveillance in both groups. Among the controls, any ejection fraction assessment that was performed after the corresponding date of heart failure or cardiac death in matched case were excluded. So based on the current practice guidelines, which do recommend ejection fraction evaluation during treatment, um, the following 2 conditions had to be met for them to say that the surveillance was up to mark. One was that the ejection fraction assessment was performed up to 6 months before starting treatment, and then there was an ejection fraction evaluation every 3 months plus minus 45 days after initiation of trastuzumab. If these 2 criteria were met, that meant that those patients and the cases and controls were adherent to the surveillance guidelines as recommended. For the analysis of the cases and controls, the continuous measures were used, which were mean or median, and conditional logistical regression was then used to estimate the odds ratio and 95% confidence intervals between the patient characteristics and the case control status. So this is the table 1 from the paper, and this goes over the patient characteristics. So I want to, of course, highlight a few points, but we'll start by how they were matched. So we can see there were 53 cases and 159 controls. They were matched for the age, like we can see. There were 57 years of age in cases and 59 in controls. They were also matched in for anthracycline exposure, and we can see about 81% of cases as well as 81% of controls had anthracyclines before getting HER2 therapy. They were then the different data then was collected on BMI, radiation exposure, metastatic disease, race, ejection fraction pre-trastuzumab, and also to different clinical conditions that they had, which included hypertension, diabetes, hyperlipidemia, coronary artery disease, arrhythmia, including the treatment that they were already on, which included beta blocker, ACE inhibitor, calcium channel blocker, aspirin, and statin. What I've tried to highlight here are the significant ones, and we can see that there was significance of a higher body mass index in cases. More of these patients were Black, and these patients, it was also significant if the ejection fraction prior to trastuzumab was 60 in cases and 65 in control, which was also significant. There was also a higher uh, hypertension rates in patients who had cardiotoxicity, as well as exposure to calcium channel blocker was also a risk among cases compared to controls. So just going over once again that cases compared to controls had a higher body mass index and were more likely to be Black compared to controls. Among the cases, the criteria for cardiotoxicity did include New York Heart Association function class 3 or 4 in 52 patients, of which 2 had preserved EF, 10 were with mid-range, and 40 with reduced EF, which was less than 40%, and there was death in one patient. So how did they manage these patients? So they go into detail about this, discontinuing and therapy. So the median interquartile range time interval between the start of the HER2 therapy and the diagnosis of cardiotoxicity was 159 days among the cases. HER2 therapy was discontinued in 51 of these 53 patients. Of the remaining 2 patients that the HER2 therapy was not discontinued, one patient did develop heart failure after the final dose of trastuzumab, and then the other patient did have metastatic disease. And given the clinical condition of that patient, they decided to continue treatment with trastuzumab. Only 3 of these patients that the therapy was discontinued in were re-challenged with trastuzumab. During the same observation therapy, HER2 targeted therapy was discontinued due to asymptomatic decline in 3 out of 159 controls, out of which only 1 patient was re-challenged after improvement of ejection fraction. The second table that the paper highlights is how were the surveillance rates, and I think this is one of the major points that the paper tries to get across is um, the compliance of ejection fraction surveillance was similar in cases and controls, and you can see it's about 60%, which was at all time points from baseline to 6 months. At final point, it was about 70% surveillance was done, and then abnormal surveillance, which they defined as ejection fraction less than 55%, was a lot more common, up to 49% among the cases and 54% at any time point. So what they concluded was that there was a very high likelihood of cases which intended to be heart failure or death of them having reduced ejection fraction less than 55%. Again, to summarize the table, there was no association that they were able to find between the adherence of surveillance of cardiotoxicity as well as heart failure. And among the 53 cases that did have cardiotoxicity, the median time interval from final surveillance of ejection fraction to heart failure event was 86 days, and the median time from the last normal ejection fraction to heart failure event was 129 days. 12 of the 53 cases did not undergo a routine ejection fraction assessment during the final 3-month surveillance interval before they developed heart failure. So this is the other important highlight of the paper, where they looked at the association between the abnormal surveillance and heart failure, and they did define that an ejection fraction less than 55% at any time point in the observation patient was highly prevalent among cases like we saw in the last table, but was not as prevalent among the controls. And this is what is described in the final month, 3-month interval as well. Of the 26 cases that did have ejection fraction less than 55%, 12 did undergo initiation or intensification of their beta blocker and ACE inhibitor therapy, of which of the 26, 7 were already on beta blocker and ACE inhibitor but did not receive any intensification of therapy. And in 7 patients, there was no beta blocker or ACE inhibitor therapy. So here they try to highlight that even though the ejection fraction was less than 55%, there was quite a few number of people, up to 27%, that did not undergo intensification or initiation of beta blocker or ACE inhibitor. So that total was 54% of patients who did not undergo intensification or initiation of therapy. They used multivariable adjusted analysis, where they came up with the ejection fraction less than any 55% during any time point during the observation period were significantly associated with heart failure development. This is the table that shows the central illustration, where the central illustration that they used in the paper, which showed that the number of heart failure cases were 53 compared to 159 controls. And you can see the rates of cardiac surveillance were similar in cases and controls, but there was a higher prevalence of ejection fraction less than 55% in cases compared to controls. Then the paper goes into the discussion that whatever, based on the results, they do mention that the risk factors associated with heart failure in this population that they saw were higher BMI, pre-existing hypertension, and race, which were consistent with the results of prior studies. So the study does confirm the retrospective and prospective studies, which do also report an increase in heart failure risk with a lower ejection fraction at baseline. And they also go on to say that the adherence to cardiac surveillance was suboptimal among cases as well as controls, which was about 60%. And I know there are papers which have shown that in the past the rates have even been as low as 30 to 40%, but nowhere close, of course, to 100%, which we think should have been the case, or should be the case. The lack of association between adherence to routine cardiac monitoring and heart failure does suggest that performance in routine ejection fraction assessment may not be enough to mitigate the risk of heart failure. And then the study, like we have discussed, did also find that abnormal ejection fraction of less than 55% did increase the risk of development of heart failure among these patients. So they did end up concluding that if abnormal ejection fraction is an early phase of cardiotoxicity, then early detection during routine surveillance, which combined with effective intervention, are likely to be of clinical benefit. And then I would like to point out that we probably know about the SOCCER trial, which is evaluating the global longitudinal strain, which does include a large amount of cancer patients who are who are being monitored for cardiotoxicity, of which 88% of patients do have breast cancer, and majority of them are on anthracycline and HER2 therapy, just showing that early surveillance may be of benefit. And I think the early 1-year result of that trial does show that there might be increased benefit of strain. So just to circle back to the point, that by the time we see a decrease in ejection fraction, might be early before development of heart failure, but we could even have a more sensitive marker as we go ahead in monitoring these patients as they receive their cancer therapy. The study also shows that ejection fraction, which was abnormal, which was detected through routine surveillance, does have important clinical implications, specifically an increased risk of heart failure. And then, the question that we all go through day in and day out, whether early intervention with cardioprotective medications that includes beta blockers and ACE inhibitors in patients who do have asymptomatic decline may prevent impairment of systolic function and halt progression to heart failure. Another important consideration is patients who do develop asymptomatic decline can continue therapy, but of course, you take into account whether you put them into cardioprotective medication while you are monitoring the ejection fraction closely with routine surveillance. The bigger question that yet is to be answered, and this was updated in the NCCN guidelines in 2016, is when they updated the guideline, they made a comment saying that though we do monitor patients on HER2 therapy with echocardiograms every 3 months, maybe this is not the perfect way because it should not be a one-size-fits-all approach on these patients. And then they made the comment that it should be based on clinical judgment and patient circumstances rather than doing it every 3 months for all the patients. And maybe that's where the 60% that we saw comes from, where people are not sure how often they should be monitoring these patients who are on trastuzumab therapy. Though I think in current practice, most of the oncologists that I know and have spoken to do try and get it every 3 months. The limitations of this study is, of course, the sample size. Like in most of the cancer studies we see, we only had a sample size of 53 cases, which does limit the power of the study. Most of these patients were exposed, so 81% of cases and 81% of controls were exposed to anthracyclines prior, which we know increases the risk substantially. In today's day and age, there is more and more use of non-anthracycline based chemotherapy, so this study might not be applicable to those patients. Because of retrospective nature of the study, there is a possibility of selection bias. And then the optimal ejection fraction monitoring interval and contribution of provider versus patient related factor were not considered or assessed because it was difficult to do so in the study. So in summary, this study does suggest that an ejection fraction less than 55% detected during surveillance is a very powerful indicator that the patient is a high risk for development of heart failure during HER2 therapy. Though additional studies are still needed to determine whether intervening with cardioprotective medication or interrupting HER2 therapy for an asymptomatic ejection fraction decline can prevent heart failure without adversely impacting the breast cancer outcomes. So that's where I will end, and I'll open the floor to questions.
Hey Tushar, thank you so much for presenting this case. One of the questions, and I would like to hear your opinion and the opinion of the rest of the group. It's on the statement that the authors make about on page 172, saying that the data supports the notion that an abnormal LVEF during targeted HER2 treatment represents a clinically relevant stage within the cardiotoxicity spectrum, and then that precedes the onset of heart failure. And then they go on saying that if an abnormal LVEF is an early phase of cardiotoxicity, then early detection of an abnormal LVEF during routine surveillance combined with effective interventions aimed at preventing progression to heart failure are likely to be of clinical benefit. So the way that I see this is that, at least in my experience, a drop in the ejection fraction is not necessarily an early event. I would say that it's closer to the end of the spectrum. And what is your take on the fact that they didn't include any other parameters?
Yeah, so thank you for the question. So yes, I agree with you, because they made the comment of an ejection fraction less than
such
55.
as LV dimensions, tissue Doppler imaging information, just like you mentioned.
I think you're cutting in and out. Hello? Hello?
Yeah, I think we lost Jose there.
Yeah, I think so too. So maybe I'll wait for Jose for a minute, but I'll make a comment that yes, I think the authors with decreased ejection fraction 55%, that's what they got, which was significant between the cases and controls, but they do not make a comment on the amount of decline. So initially, as we saw, that the baseline ejection fraction was higher in patients who were considered at controls, which was 65% compared to 60%. But they nowhere mention the amount of decline that is also beneficial. That when you either put them on cardioprotective medications or you may have to halt the HER2 therapy. I know what the guidelines say is if there is a drop in 10 or more percent below their baseline, below normal, or an absolute decrease in 16% is when you consider a significant ejection fraction drop that you would get worried about and may consider halting or initiating cardioprotective medications. I think I see a couple of, yeah, go ahead.
Hi, it's Janet Selly in Orlando. Really great presentation. I just had a curiosity about strain. If the EF is less than 55%, and we're looking at that as a powerful indicator, just in regard to 3D with strain, would the minus 17%, anything below that, be as strong an indicator, or has that not been studied? What are your thoughts on that?
So thank you for the question. I looked at the results that was published, I think in November of 2020, in the one-year results, where there, I think around 340 patients are being studied for strain. And I think the parameter that they considered was more than 10%, more than 15% decrease in strain is what they were considering significant. And an absolute number below minus or below 16%, like you just mentioned. So I think we still need to wait on the data, because the two arms in that study, one is the global longitudinal strain, and then the other arm is ejection fraction. What I did note, which is interesting and which makes sense, is there is a higher prescription that went to patients with strain, because strain is supposed to be an early marker. So a more number of patients with an abnormal strain were started on cardioprotective medications compared to patients who were being evaluated only by ejection fraction. So I do think that decrease in strain, which could be less than 16% or more than 15% drop, might be significant and might be an early indicator that we should initiate cardioprotective medications in these patients and not waiting for the ejection fraction to drop. And again, like I said, it's a 3-year trial, if I'm not mistaken. So we should see more in the coming 1 to 2 years of when we get the final results. But it does look promising, where strain does appear to be a very significant early indicator for cardiotoxicity.
Excellent. Thank you very much.
Thank you.
Hello, Tushar.
Yeah, hi.
Hi, this is Prince Autry from Kettering Medical Center, Ohio. I have a comment that I wanted to make. I think in your table 1, you mentioned that calcium channel blocker is possibly a risk factor. Could you be seen, because you mentioned also that hypertension is a risk factor. So could we be actually talking about an intermediate variable here, which is calcium channel blocker?
Yes, we could, and thank you for the question. That's a really good question, and it could be. And what the authors tried to say, they took both of them separately, where hypertension, they commented separately being a higher risk for developing it. At the same time, they said that the calcium channel blocker, they think, is the same issue that we have in patients with heart failure, with patients having low ejection fraction, are likely to have an adverse outcome. But definitely it could be a variable, like you mentioned, that could be playing a part into how.
Yeah, I think it's. Oh, go ahead. Sorry.
No,
yeah,
go
I think
ahead.
it's important. I mean, you are doing it when this is a counterfactual analysis that you are trying to do. And when you are, you are drawing your cyclic diagram. It's very, I don't have it in writing, but it's clear in my mind that you are going from hypertension, you are going to a medication that controls hypertension, and you are going to an outcome. So even though just by looking at that, you really have to be careful to call it a risk factor, because you could be, having like a really biased outcome if you.
Absolutely.
So yeah.
Yeah, no, thank you. And I think you make a very, very valid point that, these patients are going to be treated for hypertension, and, it should not be looked at that way, that these patients are a higher risk just because of being on calcium channel blockers, which, like you indicated, might be confounded.
Hello?
Excuse me, can I
Yes.
have a question?
Yes.
I have 2 to 3 questions. Thanks for your nice presentation. I have the first of my question is, the first one is, suppose that your patient is heart failure before the initiation of trastuzumab or HER2 drugs. What is your plan for which EF how much EF is allowed us to initiate the drug?
Yeah, thank you for that question. And I'm sure that there are a lot of people in the audience who are more experienced in managing patients. But what I have seen, and in my experience I have noticed, is patients who, just on a case example, we had a patient with ejection fraction of 45% before initiation, newly diagnosed breast cancer. And the only change that we made prior to initiation, because the oncologist did not want to initiate therapy with EF below 50%, was to switch. She was on diltiazem for hypertension, and it will just be a one case scenario, but we did switch her to CoReg and ACE inhibitor, and we did see improvement in EF to the point that now she is on therapy. So I think it varies from oncologists. We take consideration of what the options are for the patient, and of course we do not want to we want to help the patient undergo the treatment that they need. But I think what I have gathered from talking to different oncologists, it differs from oncologists, but usually they do not like initiating therapy if somebody's ejection fraction is 50 or below 50%. And again, I'm sure that there are people in audience who have started patients on therapy and monitored them closely if they did have EF in the borderline range or even in the low range, depending on the necessity of the treatment.
Yes, and it's a different issue. Oncologist has his or her plan. As a cardiologist, how much is good for me to initiate? For example, 35, 30. Which is the limitation of the to initiate the drug?
Yeah.
What's
So
your opinion about it?
Yeah. So I know for anthracyclines, EF being in that range, you would not put them on anthracyclines because the risk of cardiotoxicity goes up. So anything I think below 50 for anthracyclines, or even in the borderline range, 40 or below is a no-no for anthracyclines.
Yes.
For HER2 therapy, we are still learning only HER2 without anthracycline, what the risks are, and that was one thing that this paper highlighted. And I think it needs to be studied more. I think if the patient is not in heart failure and has a low EF, you could still start the cardioprotective medications and see how they do. But I don't think there's a definite marker. But of course, once you go below 40, you are looking at, you want to ensure that patients are on cardioprotective medications before you put them on HER2 and monitor them closely. So I would say for anthracyclines, it's a no if you do have a low ejection fraction, 40 or below, or even below 50. But HER2 therapy can still be considered if you have them on cardioprotective medications and they are not actively in heart failure.
Yes, as my experience, of course, I'm calling to you from Iran. As my little experience in Iran, I will begin the protective drugs for the patient for 2 weeks, and then I let him or her to initiate a drug. After one episode of drug, I call him back to have an TT, and then evaluate him for the new EF. And if the EF is the same, I will let him more and more by close observation. Do you agree with this?
Yes, I think so. I think so. That's I have had a few patients, a handful of patients that I have done the same thing, where we say 3 months, but you follow them closely clinically as well to make sure that they're not developing heart failure symptoms. But I do agree. I think keeping how the complex these patients are, I think monitoring them closely is very important. And what the protocol or the way you described how you've managed your patients, I think does make sense.
Yes, and may I have another question?
Sure.
This question is from my oncologist in our cancer hospital. They told me to ask from ICS and the more experienced man to this question. Suppose that you have a patient, breast cancer, and she had received the maximum drug of anthracycline, and the drug is finished. After that, for example, 1 year, 2 year later, she needs she have new cancer or metastasis, or she needs more anthracycline. Can we initiate the anthracycline again, and the EF is normal? In our books and guidelines, we have a limitation for the cumulative dose. Can we start the drug again?
I think once you cross that cumulative dose, I think you observe them closely, and they are a very high risk. And I think that dose comes from the studies that have been seen that once you cross that threshold, then the likelihood of them developing heart failure goes up. But of course, I don't think it takes away the fact that you can't treat them with anthracyclines, but it's just that you will have to monitor them very, very closely.
Very closely.
And those are the patients that you would consider. Those are the patients that you would consider using dextrosozane and those types of cardioprotective therapy, along with the anthracycline if it's absolutely needed.
Yeah. And also you could use biomarker. And also you could use biomarkers to monitor these patients, because if you can't get like serial echoes, if it's limited, the cancer patients get a lot of labs done. So adding on an NT-proBNP or high sensitivity troponin for close monitoring. And even this also goes for dual HER2 therapy. And your question before, like if they have a mild LV dysfunction with NYHA class 1 or class 2 symptoms, and you're considering reinitiation of HER2 therapy, you could closely monitor them on cardioprotection with cardiac biomarkers.
And that goes along with Val's question that he was asking.
Well, I think that by cumulative.
I would
excuse me. I think the cumulative dose is I think the cumulative dose is true issue. But when we have, for example, 2 years, 3 years without any complication, and the EF is normal, maybe we can initiate a drug again under close observation, as you said, by cardiac biomarker and protective drugs, and close monitoring by echocardiography. If any experience I can hear.
May I ask you a question?
Sure.
A call from Italy, Institute of Cancer in Bari. Congratulations for your nice presentation. A question about the frequency of cardiac surveillance. Because in patients who are in trastuzumab therapy for 1 year, we do it every 3 months. But in patients in trastuzumab therapy for more than 1 year, what's the frequency of cardiac surveillance? Once a year is enough in patients with the low cardiotoxicity risk? Thank you.
Thank you for the question. I think that is the biggest question, right? That how often are you getting echocardiogram? Even in the first year, if they're only on trastuzumab like this or HER2 therapy, like this paper pointed out, we do not know if 3 months is good enough. And should it be longer for people who we think have lower risk and shorter for people who have higher risk? We don't know yet. So more than a year of therapy, I would still it goes to the point that how much risk do you think the patient has and what other comorbidities they are, and like as suggested by multiple members, that cardiac biomarkers in those situations may also be very beneficial when they are receiving that therapy. If you want to space out the echocardiogram more than 3 months, especially if nothing has changed in the first year, you could use that to space it out. And I would, again, this is a judgment call. I don't think we have data in it, but I would think that you would space it slowly, where from 3 months you go to 6 months, and you use cardio biomarkers in the interim to see if you need to scan them sooner.
Thank you very much.
At WashU, our experience at WashU, basically what we try to do is at the beginning of therapy, before they ever get trastuzumab, we establish if the patient has a low cardiovascular risk or a high cardiovascular risk. For those patients who have a low cardiovascular risk, we usually get a baseline echo with GLS and biomarkers, etc. And in those low risk patients, we monitor them. We alternate between biomarkers and biomarkers plus echo. So let's say for this, after the first 3 months, we just do biomarkers. And then in 6 months, we do biomarkers and echo with strain imaging. And as long as things are going okay, we keep doing that for the first year. In the high risk, in the high cardiovascular risk patients, we usually do both at 3-month intervals for the first 12 months. And in those patients that need longer surveillance because they're going to get treated with trastuzumab or any HER2 targeted therapy for more than 12 months, we switch to a biomarker approach as long as they're doing okay and the biomarkers remain normal.
Excuse me, I have a question.
Sure.
Shadi Zandi, New Jersey Rutgers. So we are all focused on low risk patient getting the trastuzumab based therapy and then just following them based on an echo and cardiac markers. Nobody talks about the risk factors for coronary artery disease and worsening of the coronary artery disease in these patients, and the chance of acute coronary syndrome during this period of time of getting the therapy, and considering that as one of the factors contributed to worsening of the cardiac functions and low EF. Nobody talks about cardiac cath in these patients. A lot of them coming with symptoms of fatigue, exertional dyspnea, and everybody says, oh, it might be because of the side effects of the chemo. And of course, you do an echo shows a borderline EF, and we say, okay, so it's probably because of a little bit of low EF. Nobody is I'm this is what I'm seeing, and it's a little worrisome for a lot of patients. I'm a hospitalist. I do get a lot of patients coming to the hospital. They are getting their chemo, and we just do an echo when we send them home. They are all on cardioprotective therapy medications, beta blocker, ACE, and all the medications that are necessary. But we barely consider doing cardiac catheterization unless there is a very clear-cut indication, like seeing EKG changes or elevated cardiac markers. So what is the approach to getting cardiac catheterization in these patients?
Thank you for the question, and that's a very good question, and that's the biggest question, right? That we think it's the drugs, but it may be something else. And I think that is a very valid point where we are monitoring for drugs, and these patients are developing symptoms, and we just because they are cancer patients and they're going through treatments and they have other stuff going on that they symptom wise that they have with their cancer and the therapy that we attribute it to either the cancer or the treatment that we are giving them. And that's the thing, if a patient has a reduced EF, which is significant, or has a significant wall motion where one of the walls, you think the high likelihood of coronary artery disease goes up, especially in breast cancer patients who have had radiation to the left breast and may have had, more calcification with time. What I have done in a few patients is in this scenario, I have used, especially, of course, if they're very high risk and they've already had CAD, you would consider cardiac cath, especially if they have any symptom of angina with worsening ejection fraction. But in patients who have not had CAD and have mild decrease and may or may not have had radiation, I have started to use CT, so coronary calcium, as well as CTA coronary, where I have been, without exposing them to a procedure, I get the answer where, if I think they are very high likelihood to have CAD or have CAD on the coronary.
Okay.
Hello.
Thank you for
Hello.
your
Can you hear me? Can you hear
Yes.
me?
Yes.
Yeah, I'm Dr. Iqbal from Sri Lanka. Yeah, I want to ask a question. If anyone on borderline ejection fraction, like 50%, if he want to start dual HER2 therapy, in that case, our routine echocardiogram will be every 3 monthly or in a shorter duration?
Thank you for the question. I think, for now, what I have seen and observed is we've been monitoring them for 3 months. And like Dr. Alvarez here pointed out that, you could, depending on the risk factor, you could do it with biomarkers every 3 months and biomarkers and echo every 3 to 6 months. I don't think there is enough data to support it doing sooner if they are on dual HER2, leave alone single HER2 for now, which we are trying to see, how often we should do surveillance on them. But anyone else, feel free to please comment on what they think.
Excuse me, I want to tell a comment about the previous question, Dr. Zangi. I think that the most of our patients in TRUST are young women, and they usually they are not they don't have any CAD. And if we have, for example, hypertension, diabetes, and risk factors for the CAD, we can evaluate the CAD, as you said, by low EF and decreased mobility in the echocardiography.
Thank you.
Looks like Vijay Rao had a question. Vijay, you want to jump in?
Yeah, no, I just, this is a great discussion and a wonderful presentation. Just had a couple of questions. One was with respect to some patients with non-breast cancer, for example, GI malignancies that will express HER2, may end up needing Herceptin or trastuzumab much longer than 1 year. Several have sort of talked a little bit about this in terms of an algorithm, what might happen after 1 year, and whether you would, to minimize Q3 month echocardiograms with strain, to incorporate biomarkers, which I think has kind of been addressed already. But we're seeing more and more of these patients, and we're trying to figure out what the right approach is, and that maybe spacing out echocardiograms with biomarkers, as has been pointed out by the colleague from WashU, I think is probably something we're going to need to study, but I think is something that would be helpful going forward. And then my second, that's more of a comment. The second question is really about, I noticed in this particular study from Memorial Sloan Kettering, really a preeminent cancer center, where even in this day and age, with all of the data that we have, which has some limitations, we only saw about 60% compliance with the FDA label recommendations and the cancer guidelines. So I'm just curious as to what others' thoughts are in terms of what are some of the barriers that have to cardiac testing and monitoring for these patients, which I suspect is even higher in a community-based setting outside of an academic medical center. So just thoughts and comments about that. Thank you.
Yeah, thank you for that. And those are two very, very valid points. I do, and like you pointed out, 60% surveillance is in a place where you are in a big academic center compared to a community center. And there have been retrospective studies and databases which have shown it might even be as low as 30-some%. I do think that the societies, NCCN, and when the slide that I initially showed where they have pointed out that you use on clinical judgment and patient circumstance is a very vague and wide, and maybe this is one of the reason why it's not done every 3 months. And then how long do you do it is the other question. Like you said, in patients who have GI malignancies and get it longer, how long are you going to do every 3 months? So both your question and comment is very much appreciated, where we probably need to have use biomarkers and echocardiogram, and as well as risk stratify these patients as we continue to monitor. And then for cancer patient, it's the least likely group of patients where you can have an algorithm which fits all patients, right? So that is a challenge to these patients when we see them. But definitely your comment is very much appreciated, where maybe using more and more biomarkers. And the one thing that I have found very good in these patients is they get routine blood draws. So it's not difficult to get biomarkers as long as we communicate with our oncology counterparts and make sure that they get it. And that's what I have used in the patients that I have seen. And that has helped me in a few cases where we have picked up something before maybe even the 3-month period in patients who have been getting trastuzumab or may have gone longer.
Excuse me, if I have another question. If you have one choice, for example, your patient's blood pressure didn't allow you to initiate 2 drugs, between ACE inhibitor or beta blocker, which one of them you prefer? Suppose that the rate of the patient is normal, for example, 70 to 80, and which one of them you prefer to protective for her for trastuzumab?
Thank you for the question. I don't think there is been any studies to look at one or the other. And like you said, for me personally, and I would want Jose to also comment on it, that for me personally, it's on the patient, right? So if I feel that the patient is has a heart rate in the 70s, 80s, I may try a beta blocker, but it's mainly an individual case-based decision that I do. I've had patients which, like you rightly pointed out, cannot tolerate even one medication for that matter, and you have to go at a very low dose, and then you decide which one is better. But I don't think there is any clear studies that have been done, and probably something that we really need to look into, that which of these medication is better suited. But I'll leave it to Dr. Cardona here to answer.
Yeah, so one of the things that we have observed in practice is that there's a significant number of these patients who are getting HER2 therapy that develop diastolic dysfunction, and the only data that we have so far, to my knowledge, is based on the CC trial, and that's when they show that carvedilol did not affect the reduction in LV ejection fraction, but did have an impact in diastolic dysfunction. So if you're dealing with a patient who has diastolic dysfunction and diastolic heart failure, if we're going to go by data, I mean, that would be, a reasonable choice. It's not that it's wrong to choose a different agent. But from a data standpoint, you would have evidence to support that decision. However, if the patient does have HFrEF or an ejection fraction that is low, then you would just follow, the guidelines and try to incorporate both at some point, the ACE inhibitor or an RNE or and then plus minus the beta blocker.
So in low, just in, for example, EF 45 to 50, you prefer beta blocker?
So if the patient is asymptomatic and the patient has asymptomatic LV dysfunction, I would, I'll probably start an ACE inhibitor or an ARB. if they're
Yes.
asymptomatic LV dysfunction. Yeah.
And which of them, ACE inhibitor, which type you prefer? Which type of drug? For example, lisinopril or enalapril are the same, or
I mean,
prefer?
you can use whatever you have available as long as it's, you know, it's a class medication. So ACE inhibitors, or, you know, yeah.
Yes, thank you so much.
Thank you so much for this nice presentation. My name is Ewela Wika. I'm speaking from Poland. And following the previous question, I would like to ask you, what is your attitude to administer statins in cardioprotection in patients with decreased, LV ejection fraction? We have one randomized study on this topic, but do you use them routinely in the situation when you have the patient, with chemotherapy-related heart failure or decreased LV ejection fraction?
Thank you for the question. To my knowledge, I think what I have been doing in my practice, and I'll see what WashU does, but we usually go by the risk factors. And if you have a young female who has a reduction and they do not have any other risk factor, I don't see the benefit of adding statin in those situations. But of course, if you have other risk factors which may predispose them to coronary artery disease, then I would definitely consider starting them sooner than later. Did that answer your question, Sam?
Yeah, thank you. Thank you. However, due to pleiotropic statins actions, well, we may consider them as some form of protection. And I think especially in young females with left breast cancer who are undergoing radiation therapy, I think they should be monitored with cholesterol level, and I think statins should be early implemented in these patients, to protect them from increased risk of early coronary artery disease in the future.
Yeah, thank you. And I completely agree. I think patients who get radiation and which may probably with the left breast the heart may get irradiated and have a higher risk of CAD, we should definitely consider statins sooner in those patient population.
And in our practice, I mean, we routinely, at least Dr. Lenihan and I, we routinely check CRP levels in these patients, even though it's not something that it's, recommended by the guidelines in this type of population. But that's our own as any other patient that shows up to clinic for a cardiovascular risk assessment. And regardless of the cholesterol, if they have, if we consider them at to have a high cardiovascular risk and their CRP is elevated, we institute statin therapy as well. So using CRP can also help you make a decision.
Thank you for that. This is the same what we do.
Well, this has been a fantastic discussion. Great presentation, Tushar, and thank you everyone for joining the call today and for your contributions. I think it's super helpful. Next week, same time, we'll have a presentation on cardiotoxicity from immune checkpoint inhibitors from a group at Yale Medical School. So we hope you can join us then. Tushar, any closing comments or?
No, I just want to say thank you everyone for your awesome questions and your patience with the presentation, and we'll hear from you or see you at the next ICOS meeting. Thank you.
Excellent. Thank you all for joining us. Have a great day.
Thank you so much.
Thank you. Have a good time.
Thank you, everyone. Have a good day.
Thank you. Thank you so much.
Stay well.
Bye-bye.
Thank you.